Hello guys, we are back from our quick little 15-minute break. I have with me here our next speaker, Dr. Alison Norris, and would you mind introducing yourself and giving us a little bit of a talk about the African response to HIV?
Thanks very much, Bucky. Thank you for inviting me. I am happy to introduce myself. And also, I know you all have been at this all day. And so I'm happy to make this as interactive as folks are interested in doing so. I'm Alison Norris, and I'm a faculty member in the College of Public Health and the College of Medicine. And I work with Bucky now on a study about HIV and contraception, but my work for my doctoral dissertation was about HIV testing and how people thought and felt about the disease itself in Tanzania in the early 2000s. And so that's what I'm going to talk about with you today. And Bucky, I think what we planned was that I would talk for 15 minutes or so and then open up for discussion.
Yep, that's perfect.
Okay, sounds great. I can modify if you have a change in plan. Because is this the last event of the day?
We're going till 7:30, so we've got a little under 3 more hours.
Wow, I'm very impressed by all of you. Okay, I'm going to share my screen. So what you see here is a picture of Mount Kilimanjaro, the slopes of Mount Kilimanjaro here. And down below is some housing. And this is the Tanganyika Planting Company, which is a big sugar plantation in Moshi, Tanzania. And this was the site of my doctoral research. I'm going to tell you a little bit of a story about the sugar plantation and life there so that you can imagine the scene as I was living it. So sugar plantations are huge. This plantation is about the size of Columbus. And Tanzania is marked here in gray. Can you see my cursor, Bucky, when I move it?
Yep.
Okay, so this is Tanzania here. And then the next slide pops out the Kilimanjaro region of Tanzania. This is the country of Tanzania, and that black part was the Kilimanjaro region. And then this is a map of the sugar plantation itself. And these things labeled here camp are housing compounds that the people who lived and worked on the sugar plantation lived in housing that was on the sugar plantation. And sugar plantations, oh, no, we'll hold that for a second. So I'm going to bring you to where I was at the time that I was doing this work. You'll see I covered up here in white the future because I did not know it when I was there, although now I know it. And so in 1988, the first AIDS case was diagnosed in this region of Tanzania, which is called Kilimanjaro. A couple of years later, an NGO was founded. It's called Kiwakuki, and their mission was to support people living with HIV and with AIDS and their families. So this was very early in the pandemic and was an institution that endured until the time that I was there in Tanzania. Several years later, highly active antiretroviral therapy was invented, but not available to people in this part of the world. The sugar plantation where I was doing my work had been a government-owned parastatal, and in 2000 it was privatized. And the work environment changed quite a lot with that. Things became much more run by a company, so it was much stricter, and the whole environment it was harder it was a harder place to live and make a living and make a life. By 2002, when I arrived in this part of the world, people could buy, it was possible to buy highly active antiretroviral therapies in the city of Moshi, where the sugar plantation is adjacent. The reason I show this is that AIDS had been around in this region for quite a while, was known about in the community, but its treatment was not widely possible. And you'll note that there's nothing on here about testing. It was very hard to get an HIV test. So I knew what I was interested in doing. I had lived in Tanzania about 3 or 4 years by the time I started this study, and I spoke Swahili, and I had a real sense of the kind of work that I wanted to do. I was really interested in how people's lived circumstances influenced their health and their health decision making. And so this was the study that I conceived of for my PhD. I was interested in figuring out whether plantation workers should be considered a vulnerable group around sexually transmitted infections. I was interested in the stigma of HIV, both its testing and the infection itself. And I was particularly interested in a phenomenon that I heard a lot about when I was there, which is the relationship between transactional sex, alcohol, and sexually transmitted infections. So the first piece of work I did was a pilot study to understand what people talked and thought about regarding HIV. And so my first lesson learned that I will impart to you is that people do want to talk about secret and stigmatized issues. When I set out to do this work, I heard from many people, no one is going to want to talk about HIV. People are afraid of AIDS, they're afraid of HIV, it's taboo. You can't even talk about sex. And I found that I designed my entry into the research in this very roundabout way so that I could get there slowly. And on the very first day, my participants said, we can talk about all these other things if you want to, but really we should be talking about HIV. And I realized that a key thing, which is that when things are secret and stigmatized, they are hard to talk about. And that can mean that for the people for whom that is important, because they have HIV or they're fearful of HIV, having an opportunity to talk about what they think and feel with a researcher, a kind of professional environment, can be extremely welcome. And so I just say that because don't shy away from secret and stigmatized topics. In fact, they can be among the most important things to study. So this is a picture to show you what the residences looked like. People lived in this kind of very basic housing stock, 2 families to one of these small dwellings. This is a picture of one of the families that lived there who was chatting with me on a day that I was in their area. And then this is the front of her house. The housing was undergoing renovation at this time, and so this is kind of the worst version of it. But it was simple, even when it was the best version. So, and I'm showing you these pictures to show you that a big plantation like this is kind of like a small city. People lived there, there were shops, there was a hospital, there were churches, there were schools. This was a place where people lived and could spend all their time. They never really had to leave. And this is what they're doing. This was Amani Kitali, was a person who worked with me at the sugar plantation on this research study, and he's about my height. So you can see the sugar is about twice as tall as him. This is what sugar looks like when it's growing. You burn it to the ground before you cut it with these sharp knives. It's very, very dirty work because it's sooty and the earth is very dry. And then the cane was transported to this factory, mashed up and turned into sugar. And these are 3 people who had the jobs of sugar cane cutting, and it's very hard work. You can see that their clothes are completely sooty and blackened. So these are the people that I was talking to, these folks, men like this, and also many women lived and worked at the plantation as well. And so during this first piece of work, we did focus groups to talk about HIV testing and HIV disease. And we also did a small household survey. And then Amani stayed on in the plantation for 10 months and did participant observation and in-depth interviews. So one of the questions we asked on this small small household survey, was so that I could figure out if I could come back and do my PhD work. So I asked, would you have an HIV test? The first part of the study was this qualitative discussion-based data collection, but I wanted to do an Epi study. And I wanted to do a survey and have people have a test for HIV and some other STIs. And so in order to figure out whether it was feasible, I asked, would you have an HIV test? And you can see more than 70% of people said that they would. So I thought, okay, I'll come back. So I went home and did some more school and got ready, got some funding, and came back to do this work. In the meantime, okay, right. In the meantime, HIV testing became available for the first time in Moshi. It had been impossible to get an HIV test unless you were well connected at the hospital. And then by 2004, when I came back, for the first time, antiretroviral therapy was available for a limited number of people, but at no cost. So things were beginning to change around how people thought about HIV testing. These are just a few quick pictures from when I came back to the sugar plantation now a couple of years later. I was working very closely with the people who were the administrators at the camp so that I could set up a study there. And also I had my kids with me, and the one who's I'm not holding, Maggie, here is now an undergraduate herself. She's a sophomore at Hamilton College. And this child could hold me much more easily than I could hold them. So, right, as I said, I was really interested in doing this Epi study, determine the prevalence of HIV, HSV2, and syphilis, and what were the risk factors associated with having an infection. And I was going to do an interview. ACASI is audio computer assisted self-interview. It's basically you listen to an interview on headphones and you give your own answers by using a touch screen. It was cutting edge technology at the time. I'm not joking. It was like really, really super high tech. And we were going to do HIV testing, all these tests. We were going to do these lab tests. And I had the whole thing worked out in my mind, and actually then worked out logistically. And I'm going to give you a picture of what it was going to look like. I had a whole team of amazing collaborators who were had a variety of training. This woman on the left, Matilda, was a nurse, and here she's talking to a potential participant. We had the whole thing set up as a mobile laboratory and interview station so that we could move between those different camps throughout the plantation. And some of the tents we had set up for the interview. So here these people are wearing headphones and they're doing the self-interview, which is a particularly good model for when people are answering secret and stigmatized questions that they don't have to tell another person. They kind of keep the secret just between themselves and the survey. And then this is a picture of our HIV counseling, pre-test counseling setup. And the nurses did blood draws right here for people who consented to an HIV test. And then this was our little laboratory right around the corner. We ran rapid HIV tests right there. So people got their results while they waited. So this was a plan that I was thrilled about and felt like I thought I was getting maybe a PhD in logistics to get all of these things figured out. But I ran into a problem, which is that willing to have an HIV test reported on a survey doesn't necessarily mean actually wanting to have one when some researchers show up a couple of years later. People were worried about our motivation. They weren't sure who we were, that maybe we worked for the company, maybe we were trying to figure out who had HIV and those people would be fired. They were, maybe the most important piece though was a fear that people had widespread that because there was no treatment for HIV, there was a saying people had, kupima nikutenga, oh, no, I can't think of it. Well, to test is to announce the funeral. So that's a pretty somber way of thinking about an HIV test. People thought it would hasten their death. So I I knew what I wanted to do, right? And I had a lot of buy-in from a lot of people who had been working with me. This wasn't kind of an idea that I cooked up in isolation. Um, and but I also knew that if people were too fearful, there was no way the study was going to happen. So I spoke to my dissertation advisor in Moshi, my local advisor at the medical school there, who was Sabina Mtweve, and she recommended that I talk to someone named Valentina Swy, who was an activist. She was a person living with HIV who spoke publicly about her status. So I met with Valentina and we talked about this, and she was thrilled that there was going to be an opportunity for people to have an HIV test, but understood that people were scared. And so we convened a series of community meetings in all of these different sites where we were going to do our work. And Valentina came and spoke to people and told her story, which was a story of she had had HIV for a long time. And she told the story about how if you know your status, you can live intentionally, knowing that it may affect your life. And because it will affect your life, but you just either have the chance to know it or you don't have the chance to know it. And it was a tremendous gift because at that point, people started participating. When she would come, then we would start our data collection and people would participate because they would have had a chance to talk about their fears with somebody who was a truly known person to them. Not that they literally knew her, but she was, they understood her and she understood them. It wasn't a kind of a feeling of an outsider or someone who was different from them. So I think I have just a couple more images. This is my last image, which is that after I finished this work, I finished doing the data collection in 2004. And after I left, a Tanzania rolled out a set of care and treatment centers for HIV. It was their way of delivering HIV antiretroviral therapy through PEPFAR funding. And the plantation itself became a care and treatment, it became one of these centers where you could go for HIV care. And I think that my study had a tiny role to play, which is that the prevalence of HIV was very low, unexpectedly low. Everybody thought it would be much higher. And when I gave my results to the plantation about the prevalence, not about who was infected, of course, they were surprised. And I think they were then reassured that they could do something about it. I think they were worried that if they promised to take care of people with HIV and half the people at the plantation had HIV, it was going to impact their business and they weren't going to be able to manage. But the prevalence was very low, and so they could do the humanitarian thing without risking their business. And so I think then they welcomed the government to come in with this program. I thought quite a lot subsequent to that, and I think I had an ethical duty that I underperformed, which was that I think it is our responsibility to think ambitiously about what the small work we're doing can do in the place where we are. And the study was ambitious enough, but I was not ambitious enough in pushing these findings and pushing my recommendations out into the hands and eyes of the decision makers, who could have done more for the people living in this plantation, and faster. So I'm going to stop sharing here, and happy to revisit any of these things, and happy to talk with you about the sort of range of ethical and methodological, epidemiological questions that I've laid out.
Thank you, Allison, so much. That's so interesting. One question I have is it's kind of a doozy. So how do you bridge the gap between being like a white American and coming into an East African sugar plantation and saying, hey, we want to do research? Like, how do you gain their trust? How do you like navigate those race relations? Um, Especially like, I don't know, if it's the early 2000s, it's even more complicated. So how do you navigate that?
It's a great question. I think the most important thing that made it feasible to do this work was that I was um, I was very conversant in Swahili. So although I was newcomer to Moshi, I was not a newcomer to Tanzania, and um, I was able to perform all of the social engagement. I was able to perform the social roles that people do with one another um, uh, with competency. So um, so I would say that was sort of the first step. I think that to do something sensitive and challenging and not be able to talk to people wouldn't, I just don't know how it possibly would have worked. Um, but also let me really start with humility, which is that I really surrounded myself with some very excellent colleagues. And we did a lot of preparation before we started anything in the community. Really, actually, months of developing our instrument and our plans. And there was a lot of challenging each other's sort of worldview and approach. Um, it was really due to the excellence of those folks that the whole thing was a reasonable undertaking. The um, and the one other thing I was going to say is that, oh, I definitely messed up sometimes. Like um and in all kinds of ways, and it was often with the help of the sort of coming together of the team to say, okay, that didn't go that well, what should we do differently? So things certainly like this idea of Valentina coming and giving talks, um, but many times different folks that I worked with would say, like, um, this is how we're going to handle this thing. We're about to do this thing, but you think it's going to go this way. We think it's going to go a different way. And I was very fortunate to have surrounded myself by some very smart and insightful people. Um, and it's also, there's just nothing. I mean, it is like it factor that I was an American. Um, and I would say white American, but actually is more about being American than being white, was sort of more important um, in that setting.
That's a wonderful question, or that's a wonderful answer. And we have one more question from the chat. So they ask, do differences in attitude make it easier or harder to do research compared to the US? This can be the attitude of the government or the citizens.
Yeah, that's a good question. um, so there's some things that make research much easier in outside the United States, and some things that make it much harder. So in this study, I've described how it was like really kind of a challenging. People were very uncertain about HIV. Not uncertain; they were really scared, right? So it was a study that was in no small way like asking people to do something that was hard for them. I will say it was also offering them something that they wanted, right? So you can both want something and find it hard to take it up. I don't have to tell all of you who are like in college right now, right? And so, but even though it was sort of this very challenging, emotionally challenging thing for people to do, I had a huge uptake. You know, more than 80% of people who we also, I didn't even say this whole part. We did random selection. We did a randomized sample from amongst the people living in the plant in that housing. So it wasn't even like just do, oh, are you interested? Come and do this thing. We selected people and went invited them. So that adds to the challenge of recruitment. And nevertheless, we had more than 80% of people agree to come and do an interview. And then 80% of them decided to give a biologic sample for STI testing. So so on that, so I would just say there's like a different kind of cynicism in the United States. There's a ton of cynicism towards research and like I'm just gonna, I don't even care who you are, I'm gonna hang up on you and not at all interested in hearing about your study. So on that level, it was much easier to do research there. People are much more willing to participate, willing to listen to what you've got to offer. And then in this case, people were very willing to participate. I think the thing that's hard, but I'm not sure it's differently hard, is we produce science because we want to understand something going on in the world. And then the ideal would be that people who can make decisions about how money is spent would take up those findings and use them to inform decision making that would help more people. And that's hard to come by in Tanzania. It's hard to come by in the United States. So I think that's the biggest challenge. I'm not sure that it's differently challenging, but it's a similar problem.
Thank you. Jared, I know you have a question.
Yeah. So I was wondering if you've done like further research in Tanzania or like elsewhere in East Africa since your doctoral study.
Yeah, you're like, that was a long time ago. What you been up to since then? No, thank you. So this project I finished. Actually, I really, I was there for that pilot study. Then I went back for a year and did the full Epi study. And then I got more money and went back for another summer and did an ethical evaluation. And it basically was like, what are the ethical standards that cross-sectional research should have towards its participants? Because clinical trials have a certain set of ethical guidelines that they have to live up to, and observational research, cross-sectional research, often has a kind of lower threshold. So I evaluated my own study and found its ethical, both failings and places where there was tension between the two various principles of ethics, and like how we negotiated between those challenges. So this study carried on one more chapter. Then for my postdoc, I went to a different part of Tanzania. This I showed you was in the north central part of the country, in the mountains. And for my postdoc, I went to the island of Zanzibar, which is in the Indian Ocean, which is where I had lived right after college. I lived there for a year. And that was when I learned to speak Swahili. So I went back and I did a study, and in that time and place, the prevalence of contraceptive use was very low in that part of Tanzania, in Zanzibar. And so, and I was very interested in abortion also. And so I did a study looking at how people, again, talked and thought about contraception and abortion, and the challenges of unwanted and unintended pregnancy and how that played out in people's lives. And then I came to OSU, and I wanted to do a research project that was longitudinal, because I'd done these two different like cross-sectional things, and I wanted to understand how things change over time, because that's so important in people's lives, right? Like things aren't static. These studies I did, I could only see one point in time. So I worked with Jesse Quick. I know spoke with you all earlier today. So Jesse Quick was one of the people that I worked with to set up a longitudinal study in Malawi. And that one was based at a hospital, and it carried on. There was a team of people who worked for that project, and they carried on the work for 4 years. And was I was basically got the money for it and helped think about what the research questions were. So it went back and forth. And we studied both STIs, and we studied the sort of both sexual. So my first project was about sexual health. My second project was about reproductive health. But I was like, when people are having sex, they're not like, well, today I'm avoiding an unintended pregnancy and tomorrow I'll avoid an STI, right? Like it's all one life that people are living. And so I wanted to do some work that was more integrated. So that's what that project was. And that has pretty much wrapped up. And now I work with Bucky and some other folks that you all probably know on a study about abortion and contraception in Ohio. So same topic, new site.
Thank you for that. We have one more question. They say, what does HIV/AIDS care look like in Tanzania today?
That's a great question. So I'm not as well equipped to answer that as I wish they were. But a couple of interesting things. So there's still a pretty big stigma around HIV everywhere. And I think that continues to hamper both testing and treatment globally, and that's no different in Tanzania. That said, the global investment through PEPFAR and other funding mechanisms into developing a health infrastructure that could provide HIV care has been very important, both definitely in delivering HIV care, but also in creating health infrastructures that have been utilized far beyond HIV care. So the question though about testing and treatment remains. There remains the stigma around particularly women's bodies and sex is pervasive and lives strongly on today. And there are some interesting trials around PrEP in sub-Saharan Africa where people were unwilling to take PrEP because they knew it was HIV treatment, and they were unwilling to sort of be associated with anything having to do with HIV, even though in this case it meant prevention of HIV as opposed to treatment. So it's certainly gotten a lot better. And I think some of the most fundamental problems around the delivery of care for HIV is associated with stigma as much as it is with infrastructure and medicines.
So interesting. Another question we have, we are an LGBT org, so we were wondering, what does the criminalization of LGBT identities in Tanzania, like how does that impact HIV in the country, and like how does that contribute to stigma and things like that?
Thank you for that question. It's a great stain really on Tanzania and across the world, the denial of justice for LGBTQI people. And I don't, so the HIV epidemic changes, right? It's dynamic, right? It's changing everywhere. For the most part in Tanzania, it is a it is transmitted through heterosexual sex. And at one point in one study, like the biggest risk factor for having HIV was being a married woman. So, so it isn't, I don't think that it's as important. The stigmatization of LGBTQIA people, I don't think has as big an impact on HIV because HIV wasn't as concentrated in LGBTQ communities, well, amongst men who have sex with men in Tanzania as it was in other parts of the world. There is, however, a injection drug using part of the question around, well, let me say, amongst injection drug users, there's a high prevalence of HIV, especially on the coast, which is, I think, where most people who inject drugs in Tanzania live. So, so the overlaying stigmas of disease and identities and behaviors that are considered secret and bad do continue to kind of overlay and overlap on Tanzanians. I'm a little bit underinformed about that, and I may be speaking incorrectly. It may be that there is now in 2021 that there is a concentrated epidemic amongst men who have sex with men. It was not the case when I was there before.
Super interesting. And I know when I was there, we talked a lot about how the highway and the roadways really are a big impact of transmission with truckers and how they have to survive. So let's see if we have any other questions. Oh, someone said what is the most challenging part of doing research abroad for such a long period of time?
Well, I was going to put in a plug to all of you that if you like living in places that aren't your home place, to set a long goal to speak the language of that place and start chipping away at that goal. Because a place can really become home if you can talk to people. So I had the great fortune that when I finished college and wanted to not go back to school for a little while, I had a boyfriend who was living in Tanzania, and so we decided to go live there together, and I started studying Swahili. Like, I didn't speak any Swahili when I showed up, and I studied like it was my job. And I didn't really have another job, so it was easy to do that. We sort of had another piece of work we were doing, and I really had the chance to really learn to speak Swahili. So then when I came back to do my dissertation research, I became even much better at the language. And then the second project, like, everything added up. And so I really, really like living in Tanzania. I feel really like relaxed there in ways that it's hard to relax here. Life moves slower there, and I learned pretty early on that I had to move slower. I was gonna like heat up like a supernova and implode. I don't know what supernovas do, but so well, I just like that. I like myself there, and I like my life there. So going wasn't hard in some ways. Also, I had another kid after those two that you saw, so I had 3 little kids, and it's pretty hard to live on a graduate student stipend with 3 small children in the United States, but the cost of living is very low in Tanzania, so had actually a much higher quality of life there. And being with my nuclear family, we came to be very close to one another, and it was a very like formative and special time. All the different chapters, right? First, it was just me and Dodie, and then those different chapters, we came to be close. Um, so I think if I was far from my family, my like close, I was far from my parents and my siblings, and that was hard. So that was the hardest part. I think it was really mitigated by the fact that I had, even from the first time I had Dodie, I did have a family there. And when I came back to the US after the first time I went right after college, I was gone for like I was gone for a year and a half. And I came back in the winter and it was very cold. And I went to a shopping mall at Christmas time and I was so overstimulated that I like was there for about 2 minutes. I was like, cannot stay. And then in the course of about 10 minutes, I ate a Big Mac and a peach. And each one of them, I thought I was gonna like, fall apart. They were both so delicious, and I hadn't tasted anything like them in a year and a half. So, so I guess the last thing I would say, I made my pitch for language learning, and the other pitch I'll make is to go and stay somewhere if you can. I mean, what a gift! It was such a gift that I was able to do that. I didn't have any obligations to anybody else. I lived really super cheaply, but I would say it's better to go and stretch out your $4,000 for a whole year, and really live in a place. And so if you can, if you actually don't have obligations, recognize that you don't, and take advantage of just spending time in a place and getting to know it.
What sage advice. I know a lot of people on the call are fourth years or third years, so um, that's very, timely advice. We have about 3 minutes left, and this is a question from me. So I know the past president of Tanzania was not very, let's say, involved with COVID and was a COVID denier pretty hard. And he's passed away. What do you think about the new president? And like, do you think she's going to be any better? Or do you think she's also going to be a hardcore denier like he was?
Great question, and I don't know the answer at all. I know very little about her. He was also not just a COVID denier, but he also was a pro-natalist. So he was against use of contraception. He turned back some both laws and social norms which had permitted. So the laws had changed and social norms were slowly changing, that if a student in school became pregnant, she could return to school later, right? Either after she had a baby or an abortion. It had been the case she wasn't allowed to return ever again. And those norms were changing and he reversed those. So he wasn't a prize in terms of human rights of any measure. And so I don't know what she'll be like. It is possible that she'll have more progressive views around women because she is one. So that's possible. And I did see a clip when she was elected, and it was her saying, people are saying, can a woman be a president? Can a woman be a president? Well, I would like to tell you that you are looking at what a president looks like. So we can hope.
That's certainly an inspiring comment. I certainly hope that she can try and get back to letting women continue schooling. I think it's really really frustrating. Um, but we have about 1 minute left. Do you have any closing thoughts or any ideas you'd like to share with us today?
Oh, thank you. Thank you for giving me this opportunity. I don't think about this personally, to like spend 45 minutes talking and thinking about this really special time in my life is a gift to me. And I see names of people that I know and admire, including Bucky. And so thank you for inviting me today. I really appreciate that.